Let me invite the first speaker, Dr. Satish Sonar, to present his case.
Thank you, Raju sir, and whole team of Master Case Series for inviting me for this one of the unique and interesting meeting. So this is a patient who are having an injury almost 30 years back, a complex knee situation. A 46-year-old farmer, he has a history of trauma when he was an adolescent of 16-year-old while playing. He was treated conservatively because that time no MRI was done, X-rays were normal. He started doing manual farming work at the age of 19, and he had occasional instability episodes and pain. But he continued without any consultation. His first MRI was done 9 years back at the age of 37, and he was advised arthroscopy, but because of the money constraint, he didn't do any surgery, continued working amidst pain. The latest MRI and X-ray was done in 2024, and he was advised TKR. But being a farmer, has to do labor work, manual work, he was unwilling to do TKR and wished for an arthroscopic surgery. So when I examine him, he is having a varus alignment, patellofemoral tenderness with crepitus on ROM, medial joint, lateral joint tenderness, McMurray is positive for both medial as well as lateral meniscus, Lachman positive, and his range of movement was almost full. So his X-ray shows, you can see the medial joint arthritis, varus alignment, patellofemoral arthritis. The MRI, there was no ACL, it was completely absent. Lateral meniscus, medial meniscus, both were out of the joint. There was grade 4 chondral loss on the medial component, both the femoral side as well as tibial side, and grade 3 changes in the patellofemoral joint. So this is his MRI. You can see there is no meniscus in the medial compartment. Lateral meniscus is also out of the joint. There is a medial joint arthritis. Though X-rays look bad, but on MRI, patellofemoral joint looks quite well. The lateral cuts, there is no meniscus in the medial compartment. Lateral meniscus, posterior horn is not visible. So, ARS question.
So till the time the first ARS is put, let's take it to the panel. Dr. Subhash, what does the joint replacement surgeon in you think?
So I think he's not the right patient for the joint replacement because he has no pain, right?
He has pain.
He has pain, but no instability.
He has pain as well as instability and varus alignment. But being a farmer, I don't.
No, you said that he was offered surgery, but he refused for surgery.
He refused TKR. He was advised total knee replacement.
No, but arthroscopy he didn't do because of the financial issues.
Yes, yes. That was 9 years back.
Currently, he has pain and instability both.
Yes.
Okay. So the arthroscope, the MRI looks pretty fine from inside as far as the lateral compartment is concerned, as far as patellofemoral is concerned. So I would probably, because of he is a farmer, so in my opinion, he should go for an osteotomy of the proximal tibia rather than going for a joint replacement.
Osteotomy. Mark, any different suggestions from your end?
No, I agree. His ACL's gone as well, you see.
ACL gone.
Yeah, no, osteotomy would be my primary go-to for this patient.
Osteotomy. Yifta, any different point of view?
I think that arthroscopy is not an option. I think it won't help him. I think that if he declines total knee replacement, I would try injections of hyaluronic acid, PRP,
Okay.
chondrocyte enhancing product such as glucosamine, chondroitin,
Right.
until he understands that he needs a total knee. And since I don't do total knees, I would refer him to one.
Okay. I think we have the ARS now. Manjit, can we play the audio and get the audience to vote their opinion? Satish, is that the first ARS question you had in mind?
You can play the second ARS.
Manjit, play the
For the
next
treatment
ARS.
options.
Yeah, because this seems a little out of sync.
Yeah.
Correct. This is, I think, a correct option. Maybe the audio can go on and people can vote. So it'll probably take a few cases for the ARS to warm up. Right? Yeah. Right. So I think the audience seems to largely agree with the panel HTO with ACL reconstruction and meniscus surgery. Do you want to proceed, Satish?
Yes, sir. So this is one of the paper by Mark Pagnano in instruction course. He has in detail mentioned the surgical algorithm for the early arthritis because of the ligament injuries in a young patient.
Manjit, can you switch the presentation back?
And
Yes.
this is
And the timer also?
This is another paper by our own Dr. Roshan Wade, where he has reviewed the current literature regarding the high tibial osteotomy in a lax knee. So depending upon that, I proceed with the arthroscopy.
Manjit, can we have the timer too?
Medial meniscus is completely out of the joint. There's grade 4 changes over the medial tibial plateau. Lateral meniscus is also out of the joint. Since the ACL was absent for more than 30 years, the notch was completely filled with the osteophyte. I have to do the notch plasty first. There was no ACL. So this is the lateral compartment. The cartilage looks good. This is the medial meniscus, which is out of the joint. So I first release the lateral meniscus, lateral compartment, and after 2 bites in the posterior horn, the lateral meniscus can be brought into the joint. But the medial meniscus is completely stuck medially, and it was very difficult to bring it back. So I have to release all the bands from the medial part of the tibia. Still, it was very hard to bring. I further release the posterior medial tibial attachments, then I could bring it somehow within the joint. So then first I did a femoral tunnel for the ACL.
What graft did you use, Satish?
Semi-T quadruple graft. There are osteophytes at the tibial attachment of the ACL. You can see because the ACL was absent for a long time. So this is the medial meniscus repair later on. Multiple pull-out sutures followed by outside in and inside out technique.
Satish, can I just interrupt you right here and ask the opinion of the audience and the panel? What is the point that they'll go inside the knee and decide, oh, it's not worth doing a meniscus repair? So do the panelists agree with the meniscus repair in this particular patient? Any opinion?
I think on the lateral side, I agree. I think you have to do something if the posterior root's gone and if you can pull it back in. I think that the medial meniscus looked like it was quite difficult and you'd have to release along the whole medial aspect of the capsule. The only thing that I would probably add to the medial meniscal repair is a capsular plication on the medial side. So I'd put in a whole lot of percutaneous anchors and then do a capsular plication to hopefully hold it in. But I would still be worried about it going out. And I see you doing an osteotomy here. I might actually consider in this patient doing changing the slope as well, so doing an opening wedge and changing the slope.
Right.
And maybe not reconstructing the ACL if that was the case.
Right. Shekhar, your comments, please.
If you see the X-ray pictures and also the arthroscopic pictures, okay, there are a lot of osteophytes.
Yes.
And usually this kind of arthritis, you don't find laxity in these knees. So these patients are mainly arthritic and they don't really have instability. So in these cases, I would try to avoid doing much of arthroscopic work inside. Maybe I'll remove the loose pieces, loose cartilage pieces, loose meniscus, and then focus more on changing the alignment, because sooner or later this patient is going to require knee replacement surgery. So this is only a time bank procedure for say 7 to 8 years. Okay. So I would like to avoid doing many things inside the knee joint.
So your take, Shekhar, is that probably just the osteotomy, no meniscal work, no ACL work?
Yes, no ACL. There's no point making the knee more stiff.
Right. Sarthak raised his hand. Sarthak, you have a different point of view?
Sir, I think sometimes this things helps because these patients complain with synovitis, a very strict compartment. So when you try to release it and further on you go and mobilize the patient later on with the patellar mobilization and the meniscus bit of repair. So it sometimes help. Like after that, if you have given a hyaluronic acid or a depomedra, steroid in that, theoretically he might get symptomatically free and a slightly mobile knee,
Okay.
which is not might not be earlier.
Vivek?
My question is, if you are planning for TKR in the future, why are you why are you doing high tibial osteotomy? Because it will make future TKR very challenging, So if TKR is going to be required in future, because X-ray, MRI, even the bone and bone disease and arthroscopy, it looks like he will need TKR in future for sure. So I think the revision TKR after high tibial osteotomy is always be a challenge. So why not try for
he is having a pain and varus alignment. You have seen on the X-rays, there's a varus up almost about 12 degree. And there's a recent lot of literature that STO won't change the outcome of TKR in future.
So Satish, let's get that from Dr. Subhash. So Dr. Subhash, have you converted any HTOs to TKR and what difficulties have you faced?
So not converted many, though yes, it's a challenge, but I would disagree with this statement that don't do anything right now because he will need something later on. That means you should not be reducing any of the DDH or should not do any of the AVN surgeries because patient may require a surgery later on. That doesn't mean you should not do anything today. Because today he is in trouble, so we should give him at least 10-15 years, as Shekhar rightly said. And I would agree with Shekhar that if you are planning for HTO, don't reconstruct too many things inside.
Right.
Do just debridement, slope changing surgery, HTO, give him 10-15 years of pain-free life and then probably he may need a TKR. So 15 years is a long period. It's not a short period that you are time buying surgery means like few months. It's few years, another decade.
And
So-
Dr. Subhash, what have you felt that the HTO surgeon could have done differently to make joint replacement easier for you? Anything that has come to your mind so far? Or how difficult is it to convert a HTO to a TKR?
So it's primarily the slope changing surgery which will change your tibia alignment different when you
Okay.
do the TKR surgery after the HTO. And because of that, if you do the open wedge osteotomy, the patella comes down. So patella baha is a problem.
Right.
But that's a problem with a lot of Indian patients. So I don't see a major challenge there if you have done a good osteotomy and if you remove the implant after surgery.
Okay, and in case you have not removed the implant, then you obviously have the robotic
it's a-
technology to help you.
Then it's a problem, yeah.
Right.
So good morning, sir. So
Yeah.
even though with this much of arthritis, if you do only HTO, it works well because this patient doesn't have so much instability and you have to reverse the slope in HTO. And again, another thing for a future TKR, if you go for infra, then you don't have that patella baha complication. So nowadays, those who have a more than 10 degree or 12 degree varus alignment, generally surgeons prefer go below the TT.
Correct.
So to prevent the patella baha complication, that works well while doing a convert into the TKR in the
Noted.
future.
One last comment from Mukesh and then we are at the 5-minute mark where Satish has to
think
finish.
I differ from Vivek. If a properly done HTO, not overcorrection, doesn't affect the future TKR.
Right.
What affects is the bad slope. So we are not looking here because of arthritic knee, he is having pain more compared to instability. So my preference here would be only do a lateral meniscus repair and a neutral alignment, get only up to 50-52% of
Correct.
HTO.
So it's the
Don't
change
go
in
beyond.
slope which worries more as a joint replacement surgeon for future TKR. Satish, can you please wrap it up? Now we are at
Yeah,
the 5-minute
so
mark.
this is a picture after the medial meniscus and lateral meniscus repair. So there is a complete coverage of the lateral compartment. This is a ACL which was reconstructed. So then this is a 12-degree correcting medial open wedge osteotomy. I have not changed the slope. So this is a final video. The ACLR. This is, sorry.
It's interesting you have used a Pudu plate for such a large correction. Shows your confidence in these small plates. I mean, I would probably have been a bit more comfortable with something like a Tomofix.
Yes, 3 tunnels. So this, I know, so this is after 6 months, and this is recently after 9 months. His slope is not changed. The medial and lateral compartment gaps are equal, and he is doing well. He's full. He can do all this manual work, squatting, square leg sitting.
How old is he, Satish? 47?
46.
46. Yeah.
So the knee is stable. So there are a lot of papers. This is a paper by Hernandez in sports medicine. There is a high return to sports after ligament reconstruction and HTO. This is a long series by Jin in BMG Musculoskeletal Disorder Journal, which they have compared the outcomes of the HTO with ligament reconstruction in early arthritic patient. So my take-home message is, in young arthritic knees, it is always challenging to treat, and what should we offer them. Injuries happens during the adolescence, can complicate the management because everything can change, the meniscus, the cartilage and the ligament. But below 50 years, if the patient is a farmer, laborer, you can offer him a joint preserving surgery. But TKR is always an option if the patient is sedentary and above 50 years. Thank you very much.
Thanks. I think it's a good case. We still have 2-3 minutes left for any comments or discussion. So any quick comments from the floor? Yes, Sarthak?
Any brace?
I use a long knee brace for 3 weeks, followed by a functional knee brace for another 3 weeks.
Did you plan for any offloading knee braces?
No, no offloading.
So any comments from any of our audience? Srinivas? Yes?
I think the key here is the lateral compartment articular cartilage condition. I presume the lateral compartment.
Lateral compartment was absolutely good, very pristine. So though on X-rays you can see the osteophytes on the outer aspect, but the weight-bearing area and the cartilage were almost normal.
Wonderful. Yeah, Dr. Singh.
Dr. Sonar, it is written 24-year-old in the schedule, program schedule.
No,
is
it was
patient 24-year-old or the
46-year-old.
Okay.
The injury was almost 30-year-old.
Okay.
When he was 16-year-old.
Thank you.
Can anyone answer how long will it last and how to counsel the patient in such cases? This kind of surgeries, panelists or seniors, anyone? What is going to be the prognosis and how you explain the patient it will last for 5 years, 10 years?
That was my first question in ARS 1. So how to counsel the patient and what should he expect from us?
So if I have to counsel a patient with HTO, I would say that if your normal compartment on the medial side has lasted for 40 years, and if we change the weight bearing to the other compartment, probably should last for at least 20 years. If everything has been done properly, it should last for 20 years approximately.
Thank you so much, Satish.